Okay, so we will discuss about the diabetes insipidus now. So, diabetes insipidus, it's the pituitary function. If it's hampered, then the diabetes insipidus will takes place. So, diabetes insipidus may result from deficiency of the ADH secretion, uh, cranial diabetes insipidus, or from an inappropriate renal response to the ADH. Okay, that's called the nephrogenic diabetes insipidus. If the deficiency of the ADH, then it's called cranial diabetes insipidus. And if the secretion of the ADH from is there, but the inappropriate response from by the renal system, then it's called the nephrogenic diabetes insipidus. As a result, fluid resorption at the kidney, fluid reabsorption at the kidney is impaired, resulting in large amount of the hypotonic dilute urine being passed with the profound uh, unquenchable polydipsia. Okay, so it will result in the polydipsia due to the fluid reabsorption at the kidney is impaired. That's caused the large amount of the hypotonic dilute urine being passed in the through the kidney. What is the biochemical features? So the biochemical hallmarks of the diabetes insipidus are the high plasma osmolality. The osmolality will be high due to the increased urine outflow, which is very diluted. So the osmolality will be greater than 295. Then low urine osmolality. Urine osmolality will be very low, is less than 300 milliosmol per kg, and hypernatremias. Okay, because with water the sodium will be also excreted, and sorry due to the urine will be very diluted, the concentration of the sodium in the blood will be increased, because it's not excreted. So the blood sodium level will be greater than 145 millimole per liter and high urine volume. Okay, so we have seen that biochemical features, the hallmark are the high plasma osmolarity, low urine osmolarity, high sodium plasma concentration that's greater than 145 millimole per liter, and the high urine outflow, high urine volume. Then causes. What are the causes of the diabetes insipidus? So the cranial ADH deficiency. The causes are the inflammatory hypophysitis. Okay, inflammatory hypophysitis, then the histiocytosis X, and the post pituitary surgery. Okay, the inflammatory hypophysitis, then the histiocytosis X, and the post pituitary surgery. Inflammatory hypophysitis, histiocytosis, and the post-pituitary surgery. Then nephrogenic ADH resistance is the metabolic or electrolyte disturbance. Then the renal disease or drugs like lithium. Okay, the nephrogenic diabetes insipidus will be occur due to lithium. Then renal disease and the metabolic or electrolyte disturbance. Then an ADH stimulation test can distinguish between cranial and nephrogenic diabetes insipidus. As nephrogenic diabetes insipidus shows an inability to concentrate urine even after the administration of the synthetic antidiuretic hormone. Okay, so it will suggest that this is the uh, nephrogenic diabetes insipidus, because after giving the synthetic antidiuretic hormone, which is increase the decrease the effect of the diabetes insipidus if it's the cranial diabetes insipidus. Okay, because there is the deficiency antidiuretic hormone occur in the cranial diabetes insipidus. Then what is the management? So patient with the confirmed cranial antidiuretic hormone should be investigated for pituitary disease and managed as appropriate. Cranial diabetes insipidus typically responds well to the synthetic antidiuretic hormone administration and result in the good clinical impairment. Okay, in nephrogenic diabetes insipidus, the underlying causes should be considered and reversed where possible. If symptoms persist, patients should drink according to this and according to thirst and keep up with water loss. Specific measures to treat nephrogenic diabetes insipidus include the use of low salt, low protein diet, diuretics, and the NSAIDs. Okay, the underlying causes should be considered and reversed where possible. If symptoms persist, patients should drink according to the thirst and keep up with water loss. Specific measure to treat the nephrogenic diabetes insipidus: the use of low salt, low protein diet, diuretics, and the NSAIDs.